the JAMA Network.
I'm Professor Debbie Lawler. I'm from the Medical Research Council Integrative Epidemiology Unit at the University of Bristol in the UK. We were interested in whether the common clinical perception that if a couple have had 3 or 4 treatment cycles with IVF and they haven't had a successful live birth, whether that is it, whether it's very unlikely that they will have future success, which is how a lot of clinical practice happens, and insurance companies and national health services tend to limit treatments around that 3 or 4 number of embryo replacements. So the objective was to see, with a treatment cycle defined as ovarian stimulation with all subsequent fresh and frozen embryo transfers from that one stimulation, what the live birth rate was for the first such cycle and what the cumulative live birth rate was across subsequent treatment cycles up to the 9th cycle. We looked at all women in the UK who had had IVF treatment between 2003 and 2010 for the purposes of getting pregnant. So we excluded women for surrogacy or for donation. And then we looked at live birth rates in those women with those treatment cycles up to 2012. The live birth rate continued to increase cumulative right up to the 9th treatment cycle, and that after 5 or 6 treatment cycles, the live birth rate was around the high 60s, 70%, similar to what you would see after 12 months in a couple trying to conceive naturally. So we were seeing rates that for the IVF treatment group took around 2 years, similar live birth success rates cumulatively over several cycles that were similar to natural conception. But we saw some difference by age and treatment type. In particular, those high success rates were there for women under 40, who were the majority of the cohort. For women aged 40 to 42, they also continued to increase their chances of success cumulatively up to the 9th cycle. But for those women, they achieved at the sort of 6th cycle a cumulative live birth rate of 32% as compared to 68% in the younger women. And then for women who were 42 years or older, they really had poor success rates both within each treatment cycle and cumulatively. It didn't really seem to increase. That in one stimulation, a woman may have even no eggs retrieved or a very small number. With a subsequent ovarian stimulation, it was like she was back to the start again. She had the same likelihood of having a high success rate. For couples embarking on IVF, they should think of it as a long-term treatment. And by long-term, that could be 2 to 3 years. They should think that they may not be successful with the first ovarian stimulation and treatment cycle or with the second or third, but they could gain success if they continue beyond that. And clinicians also should understand that stopping after 3 or 4 cycles is not evidence-based. That doesn't mean to say that continuing for more cycles is right for everybody, but we feel that couples and clinicians need to know what this evidence base shows. Using the same data set, but without cycles linked to individual women, we've developed a tool that allows couples to predict what their likelihood of success is for a single cycle. What we want to do now is combine that work with this more recent work to develop a prediction algorithm for what will help couples and clinicians to predict their cumulative live birth success rate, so a sort of more individualised approach. The other important thing that we're going to look at is whether there are any adverse effects of such repeated treatment. So here we focused on what's the real reason behind IVF, which is to have a successful live birth. But what we want to make sure is that that's not at the expense of any ill effects. And we're going to look at whether, from the mother's point of view, repeated ovarian stimulation may increase her risk of what's a quite rare outcome of hyperovarian stimulation syndrome, but also for the babies, to make sure that by increasing the live birth rate, we're not increasing the number of babies who are small or who are born preterm.